So I'll start by saying on behalf of the Greater Tompkins County Municipal Health Insurance Consortium, we welcome you to this 2017 educational retreat. We thank you for taking time from your very busy schedules to join us today for learning, collaborating with the objective of increasing everyone's knowledge about the business that we're in so that in the future, the consortium can even be more successful for many years to come. I am Don Barber. I'm the Executive Director for the Health Consortium. And a few housekeeping items for you. First is you should take care of yourself at this meeting. This is about healthcare, right? So if you need to stretch. There's a bathroom right over here, and it's for us to use, so you haven't got to go to another floor. There's water over here at the little canteen, so you're welcome for that. There's coffee and so on available. Also, if you need to stretch, just get up and stretch. That's important to keep your body fresh. All right, here's our retreat agenda. You have it in your packet. So the presenters and I have a very strict time schedule to get all of us done on time, and we'll be breaking after managing healthcare costs for 15 minutes so you can refresh your coffee cups and another bite of donut. And our goal is to be done by 11:30. So if you skipped ahead and you see there's a question and answer at the very end, I'll let you know that we would love to have questions as we're proceeding. So there may be terms or concepts that are new to you and you want to get better information and more clarification, so please ask questions at that time. So the introductions are, of course, I've introduced myself. Next to me is Steve Losey, our benefit plan consultant from Losey and Cahill. And then next to Steve is Beth Miller from Excelis Blue Cross Blue Shield. She is our account manager. And then Megan Feely from ProAct. And Megan, you have an associate?
Yep, this is Austin Washburn. He's one of our clinical pharmacists.
And then Beth, we have Ken's going to join us later.
Certainly. Okay,
so Ken, we'll introduce Ken later. And also Dr. Marty Stallone from Huga Medical Center will be joining us to be part of the presentation. So also, I'd like to have, at this time, have all of you state who you are and your relationship to the consortium so we know who's in the room. We'll start over here.
Jeff Walker with the Village of Cuca Heights.
And your role?
Deputy Clerk.
Thank you.
Hi, my name is Laura Shawley, and I'm on the Board of Directors for the Town of Danby. I'm also the Vice Chair of the Joint Committee of Plan, Structure, and Design, and on the Finance Committee.
Hi, I'm Mark Whitmer. I'm the Town Supervisor in Caroline.
Hi, I'm Steve Thayer, City Controller for the City of Ithaca, also on the Chair for the Audit and Finance Committee and also on the Board of Directors.
Hi, I'm Judy Drake, Town of Ithaca Human Resource Manager, and I'm also the Chair of the Consortium.
I'm Debbie Kelly from the Town of Ithaca. I'm bookkeeper there, and I on the Own Your Own Health.
Mike Murphy, Dryden Village Trustee.
Chuck Rankin, Clerk Treasurer, Administrator of the Village of Groton. I'm also on the Audit and Finance Committee for the Consortium, and I'm Secretary to the Consortium.
Hi, I'm Nancy Niswinder. I'm with the Village of Groton. I'm the Deputy Treasurer.
I'm Eric Snow. I'm from the Town of Virgil. I'm on the Town Board in Virgil.
Please, Matt.
Matt Cook with the City of Cortland. I serve with Steve on the Finance Committee and also on the Board of Directors.
I'm Beverly Chin. I'm from the Human Services Coalition, and I'm on the Owning Your Own Health Committee.
I'm Ted Shealy, Tompkins County Health Department, and I am the chair of the Owning Your Own Health Committee.
Emily Mallard, sorry, Director of Care Management with Cayuga Area Plan, and I'm also on the Owning Your Own Health Committee meeting.
Thank you. Hi, I'm Shelley Michelle Nunn, Director of Human Resources for the City of Ithaca, and I'm on the Joint Committee Plan, Structure, and Design.
Hi, I'm Susan Dunlop from the Tompkins County Health Department.
Bud Shattuck, Mayor of the Village of Union Springs.
Hi, I'm Carissa Parlato. I'm the Town Clerk from the Town of Ulysses, and I'm on the Joint Committee for Structure and Plan and Design, something like that.
I'm Nina Thompson. I'm the relatively new bookkeeper for the Town of Ulysses.
Thank you all, and welcome. I also like to acknowledge Michelle Potteroff. She's probably, I'm not sure where she is. She's around here someplace. But she definitely pulls all this together and is a real asset for the consortium. So thank you, Michelle. And also Jim Blizzard, who's looking at us from up above. Jim is doing the videotaping today, so I want to thank you. And here comes Dr. Marty Stallone. So welcome. I sort of given you an introduction, and we'll see you a little bit later.
Yes.
So, thank you. Okay, the first section today then is the refresher from previous retreats, as well as an update from on the state of the consortium. So from our previous retreats, healthcare is a diagnosis, treatment, and prevention of disease, illness, injury, and other physical and mental impairments in human beings. Healthcare is delivered by practitioners in allied health, dentistry, nursing, optometry, pharmacy, psychology, and others. It refers to the work done in the primary, secondary, tertiary care, as well as in public health. Make no doubt, healthcare is a business. Patients purchase healthcare products and/or services from the private sector medical care providers and/or facilities. And it is a big business. In 2015, healthcare spending in the United States accounted for 17% of the gross domestic product. And healthcare is important to also note that its cost grows much faster than inflation for all the other consumer price index tracks goods and services. So then the question is, why do I need healthcare and health insurance? Well, illness, disease, and injury are unpredictable events, and the cost of service is very high. In fact, 20% of the population spends 80% of the premium dollars collected. And the Affordable Care Act requires that you have health insurance. So to summarize, one never knows when health insurance will be needed, and they never know when a loved one or they themselves will need the advanced healthcare techniques that can be very costly. So then what is health insurance? Health insurance begins as a risk pool where a group of subscribers pay premiums into a pool which pays healthcare claims. The risk pool creates benefit plans which establish a level of benefit. The insurance company pays the provider on behalf of the subscriber based on the terms of the benefit plan. Risk pools are successful when they have a large number of subscribers and a predictable demographic of ages and genders. So moving on to benefit plans. Benefit plans are contracts actually between persons and their employer with a licensed insurance company. And benefit plans contain a list of covered medical services. Health insurance companies typically contract with healthcare service providers that offer medical care and services to you at a reduced but agreed upon amount. This is called the provider network, and we will spend a little time on this describing it later. Benefit plans must meet federal and state requirements called mandated benefits. Benefit plans describe also the patient's portion of costs for healthcare services. So you will probably recognize all of these terms that are defined in your plan, and Steve Losey will be spending a little more time on these, except for the last one, the non-covered products and services, which are either stated in your plan as they will not be covered, or they are not covered because they're not in your plan. So, but those are definitely fully paid for by the subscriber. So this slide is really to grab your attention about why risk pools are so important. This is data from an actual upstate New York risk pool, and you'll notice that one claim is over $2.7 million. And the 7 people amassed nearly $500 million in healthcare expenses in 1 year. The risk pool needs a lot of subscribers to absorb this type of loss. We are part of a risk pool in the event that we or a loved one need this level of care. This slide summarizes the concept I just mentioned in the previous slide, and then asks the question, how can benefit plans, patients, providers, and insurance companies work together to collectively keep us healthy and manage costs? And that is really the focus of today's retreat. Those of you that have been to this retreat probably recognize, I love it, recognize this stool, 3 legs always defines a plane. And one leg then is a patient who needs healthcare services. And another leg is a provider of that service. And the third leg is a health insurance adjuster, whether it's a third-party administrator or a prescription benefits manager who pays claims based on the language of the benefit plan. And this benefit plan is a contract then, the same contract between the subscriber and the provider. Municipal employees provide health insurance to their employees because they understand the importance for both the employee and their dependents of having security when the unexpected happens. And the provider also needs to be secure in the knowledge that they will receive compensation when they provide these services, which are usually unplanned and often of an emergency on some level. So how do insurance pools work? So let's dig a little deeper into that concept. Risk pools are defined as individuals collectively grouping their funds to pay health care costs. Pooling risks with others provides security from personal financial catastrophe. If the group is of a diverse demographic and large enough, statistical studies by an actuary can predict fairly accurately the cost of health care for that pool, which helps you then establish your premium. The risk pool implements strategies such as provider networks and collaboration, subscriber sharing of costs, preventive health care, and so on to contain costs. This slide shows, for the different risk models, the risk borne by the employer and the health insurance carrier. For the community-rated model, which is at one end of the spectrum, all the risks are held by the carrier or the insurance company. For the self-funded, all the risk is carried by the employer, which is at the other end of the spectrum. And experience-rated are in between, which the risk is shared between the employer and the insurance company. For the Health Consortium, we are considered one community so that every municipality loses its identity when it joins the consortium. But at the same time, with this model, we are actually considered a self-insured model, fully to one end, which the consortium then assumes all the risk to pay all the claims except that which it cedes to a reinsurer for large loss claims. This is called stop loss, and we'll be talking briefly about that coming up. The reason the Health Consortium is so attractive to municipalities that just joined in 2017 is that they were in the market buying community-rated products, which are the most expensive because the carrier is carrying all the risk. By joining the consortium, they entered the self-insured model, which is the least expensive due to the Health Consortium assuming all of the risk. So consortium risk level, this slide summarizes my comments on the previous graphic, and it also highlights that in New York State, employers that have fewer than 100 employees must buy the expensive community-rated product or join an Article 47, which the Greater Tompkins Health Consortium is in Article 47. And Article 47 is a unique insurance model and rarely found for a municipal corporation to have one available. It is the only self-insured model available for employers with fewer than 100 employees. And it takes a lot to create an Article 47. For those of you that were around at the beginning, creating the municipal cooperative agreement was no small feat. I thank Steve Losey and Losey and Cahill for their heroic efforts to help bring this together, as well as the municipal partners. But also, an Article 47 requires that you create and maintain statutory reserves that are required to make sure that the fund has enough money to pay all the claims and all the exposure brought forward. And the Article 47 must develop benefit plans that are then approved by the Department of Financial Services. Article 47 also requires a role for labor. Within the Health Consortium, labor has roles as both directors and the majority of the membership on the Joint Committee. Article 47s are regulated by the Department of Financial Services to ensure security of the plan for the subscriber that depends on this insurance model for their financial security. Just a little note at the bottom that we received our certificate of authority on October 1st, 2010 and began operation in 2011. So in terms of health insurance companies, we're still very new, but in terms of experience from Losey and Cahill and Excelis and ProAct to help us, we actually have quite a bit of experience behind us. Who was in the consortium? We started out with just Tompkins County and the 13 municipalities that joined. And since that time, the consortium has expanded to include all the contiguous counties, which are Cayuga, Chemung, Cortland, Schuyler, Seneca, and Tioga counties. And currently, we enjoy the support of both Cortland and Cayuga County municipalities. This is our roster of municipalities that have joined, and we're up to 28. We started with 13, so we are definitely growing, which is something that the Department of Financial Services is having a little trouble with. They're not used to consortiums actually growing like this. I wanted to highlight this slide because this is important work that was done by the board and committees within the consortium. It states our mission statement, which I will repeat as the Greater Tompkins Municipal Health Insurance Consortium is an efficient intermunicipal cooperative that provides high-quality, cost-stable health insurance for our members and their employees and retirees. And our vision is to provide health insurance by collaborating with claims administrators, providers, and employee representatives to manage costs, to provide a trustworthy, responsive, and efficient access to quality products and information, to educate our members to become more directly involved in their own personal health. And lastly, to promote a culture of preventive health care for the well-being of its members. So we've been talking about risk pool, and this is the synopsis of our risk pool. You can see that we started out with 2,000 contracts, employees and retirees, and we're currently at 2,350. And you can see the covered lives in the blue up above. This slide you've seen every other retreat, and if you've seen any of the Board of Directors material, this is our income distribution. 98% of our revenue comes from premium. And the next slide is really important in that this shows where our expense distribution goes. 93% of our expenses goes to pay claims. 3% goes to pay administrative fees to Excellus and ProAct for administrating our claims activity. 2% for stop-loss insurance, that's the reinsurance that we pay for the unexpected large claims. And the remaining 2% for taxes, fees, professional services, and ancillary benefits. The real highlight from this chart is that in the private sector, they're operating between 80 and 85% efficiency, whereas the consortium is at 93%. This is the reason why we are such a great deal for all municipal corporations within New York State. And this slide, it just gives you a little history about where we've been going as a consortium. The second column, which has the health insurance premium increase since we started up. For the first 3 years, we were building the statutory reserves, but even with those heavy premium increases, we were still maintaining increases that were less than the private sector. And once reserves were built, which is the year 2015, the Board of Directors could justify lower rate increases. And if you compare the third column, which shows the rate of increase for Excellus, you'll see that the consortium premium rates are lagging Excellus during this whole time. And they're running experience-rated and community-rated plans, which would be the reasons why we're comparing a self-insured to a different type of plan model. And referring back to slide 24, the reason is just the efficiency of the consortium structure. We have very little overhead above paying claims. Insurance premiums differ. Insurance premium differences are savings to the employees and the taxpayers are currently accumulating more than $2 million every year. And now I'm going to pass along this is our review. Hopefully there weren't any questions. Of course, I wasn't looking behind me to see, but I will for whenever Steve starts talking. Steve, it's up to you.
All right. Thank you very much, Don. All right, I'm going to go through the next few slides, and then Beth Miller and Megan Feely are going to go through some information relative to Excellus and ProAct, respectively. If you turn to slide 27 on to 28, just in terms of choices of service providers, this is starting to get into some of the discussion about patients, how they can impact costs through the choices that they make, and just kind of going through some of the nuts and bolts, if you will, of the process of seeking care and then having that care covered by the health insurance plan. So the first thing that we have to decide as patients or covered members is where's the appropriate place for us to seek out care. And we have a number of choices in terms of where we can go for that. Obviously, the private physician's office is our primary focus typically. Any type of healthcare specialist, whether it's an orthopedic surgeon, neurologist, et cetera. Obviously, hospitals and care centers. Care centers could be ambulatory surgical facilities. They could be renal dialysis centers. There's a number of different facilities we can go to. Urgent care being other types of brick and mortar type facilities that you can go to for care. Obviously, pharmacies are a big part of what we do today in terms of health care and health insurance. Today, it equates to about 30% of our total spend in terms of the health insurance dollars that go out. And certainly, critical decisions that folks make at the pharmacies, are key to what happens with the overall premium and expenses of the cooperative. And then the very last thing, preventive health care. Obviously, preventive health care, if we can take better care of ourselves, ideally will reduce expenses down the road. Now, in terms of kind of the flow, this is kind of a busy diagram, if you will, but it kind of gives you an idea of some of the basic mechanics of the flow of what happens when we do seek care. So, we're ill, whatever, we get injured. We seek care from a medical provider or a facility. Once we have that care rendered, obviously there's going to be a bill for that care. Sometimes, depending on the type of contract you have, you may have to pay part of that cost of care at the time of service. Typically, that would be in our PPO program. So if you have a flat copay, most physician offices are going to expect you to pay your copay at the time of service. If you have an indemnity plan, a plan that's usually subject to deductible, and you're paying a percentage of the allowed amount, the physician won't bill you typically at the time of service. They will submit the claim to the appropriate entity, whether it be ProAct or Excellus. Once they make their determination and pay, you ultimately would get a bill. So there's a couple different points here after you go to the physician's office where monies will be transacted from. Obviously the patient to the right, and then to the left, we've got the bill going to the insurance carrier or prescription benefit manager. Once they take a look at it, they adjudicate it through their systems, look to see if it's a covered item, determine what the exact amount would be that would be paid based on discounting or allowed amount methodologies. They'll pay the provider that discounted amount. If it's a paid in full benefit and they're a participating provider, there's nothing for the patient to do. Again, if there is deductible or coinsurance involved, typically the patient will be getting a bill after it's been adjudicated by the insurance carrier. The other time that you will get a bill is for services from a non-participating provider or someone who isn't under contract with Excellus or ProAct. If you seek service from them, they may bill you above what the insurance carrier allows up to their billed amount. So there could be some balance billing in there, but generally speaking, most people are going to be subject to a copay, a deductible, or a percentage of payment in terms of coinsurance of the allowed amount. And that does cap the expenses not only to the member, but what we pay through the consortium. Also in the top right-hand portion of the page, you'll see some common questions to ask your doctor. We'll be going over this in a little bit more detail later on in the presentation, but it's things to think about as we start to go through that. What are my treatment options? What services will be performed? A lot of times we go in and they start pointing us in directions and sending us to various rooms. We don't ask what they're for or what they're drawing blood for or what the service is actually going to be rendered sometimes. So we need to know what that is. What services do I really need? Okay, we're going to get a lab panel. We're going to do this. We're going to do that. Okay, what's each one of those for? What do I really need? What's for just kind of protective for the physician versus what's really going to be needed to be for diagnostic purposes. Obviously, seeing if you can control that to some degree. How much will the services cost? I never ask. Most people don't. And then, especially with medications, are there lower cost alternatives? Obviously, generic drugs being the lowest cost. Are there any of those available for me? In terms of common places of treatment, we've covered some of them. You're familiar with all of these, but In terms of places where we seek out care, obviously the hospital, both inpatient and outpatient services. We go to the emergency room. Obviously, when we have elder care, significantly, skilled nursing facilities are utilized. Ambulatory surgical facilities are used more today than they've ever been used. There's a lot more outpatient surgeries done today that used to be inpatient. The care is good for those, and obviously that's a very common place of treatment that we see these days. Urgent care facilities are becoming more popular, trying to bridge that gap between the physician's office and the ER for things that are not quite critical emergencies, but emergent enough that if it's after hours and you can't get to the physician, you need to seek out care, you've got those urgent care facilities available. Obviously, psychiatric substance abuse facilities, those obviously are growing. That's a growing expense for a lot of health plans with the changes to the mandated benefits through the Affordable Care Act and also the Mental Health Parity Act in New York State. Physicians' offices, again, that's your primary contact for most of our care. Patients' residents, we do sometimes receive home care. Even physicians will come to the house every once in a while. We're going to talk a little bit about telemedicine, which would be care delivered to you at your home. And then obviously the 3 locations for pharmacy. We've got the retail pharmacy, which is kind of the brick and mortar pharmacy that you go to, the mail order, and then you have your specialty drug pharmacy for all the really expensive and high-cost drugs that are out there these days in terms of biomed drugs and others to treat our illnesses and our injuries. Common types of services, primary care, again, being number 1 there, and immunizations. It's obviously what we're all trying to encourage people to do is make sure that they're getting their annual physicals and getting their immunizations and getting all the tests that they need to have done. Diagnostic lab and x-ray, obviously another big component of what the medical plan provides. Convenient care, after hours care, urgent care, emergency care. Talked a bit about that. Specialty care, again, your orthopedic surgeons, your oncologists, cardiologists, et cetera. Surgical services, whether you have a surgeon, assistant surgeon, anesthesia, all of those elements, therapy services, physical, speech, occupational, rehabilitation services, whether it be physical or mental health, and then obviously pharmaceuticals and meds, big components of what is provided. In terms of prescription drugs, just a little bit of a quick overview of the different types of prescription drug programs that we have. We really have 2 types of programs. We have one where the drugs are lumped into basically 2 categories, and then we have another where it's lumped into 3, and now we kind of have this offshoot category of specialty meds that we'll talk about a little bit too. In some of our older 2-tier style programs, it's pretty simple. You have a copay for generic and you have a copay for brand name drugs. Pretty straightforward. In our 3-tier setups, those brand name drugs are now broken down into 2 different components. We have preferred and non-preferred, so tier 2 and tier 3. Typically, tier 1 is going to be your lowest cost. We have 82% of the prescriptions filled today are filled with those generic medications on a tier 1 basis. That means about 18% are everything else. Out of that 18%, 1.22% of the prescriptions filled in total are specialty meds, and the specialty meds, in terms of an overall spend, is about 35% of our total costs on the pharmacy side. So that's a big ticket item that we're really starting to focus on from a cost management perspective, and we're going to be getting out more information on that as we get through the presentation. In terms of preventive care, again, just a little bit of a public service announcement here, I guess, more than anything. Making healthy decisions and taking positive action regarding health, nutrition, relationships, exercise, et cetera, can lead to a better quality of life. And obviously, we're also hoping that it leads to lower costs to the plan and lower costs to the members as well in terms of delivery of health care. Where do we spend our money as members covered under the plans? In a lot of cases, we're sharing in premium costs. Employees and retirees are paying a contribution towards the premium in most cases. Many of them have deductibles built into their programs, co-insurance amounts at 20% that we pay, or in some of the metal level plans even higher than that, 30 or 40% in terms of co-insurance amounts. The flat dollar co-payments, whether they be on the medical or prescription drug side. Out-of-network balance billing, again, It's our goal that nobody gets balance billing and everybody tries to stay in-network when they can, but we still do have about 2% of the claims population that goes out of network in any given year. And then obviously we do have some non-covered products or services, things that just aren't covered by health insurance, which the list is very small these days. It's more things are covered than they've ever been covered before and at a much greater level. But there are some things that you may still have to pay out of pocket for, like over-the-counter medications and things of that nature. With that, I'll turn it over to Beth and Megan to go through some information about their web pages and some other information about their programs. Beth?
Great. Really what I wanted to bring to everyone's attention is our new web redesign. This has been most recent the last few months. They continue to work on the master redesign of our web view. It is now user-friendly for all mobile devices, so it fits to the screen. But what you will see is a very user-friendly content. They've actually did quite a study to revamp our web page, and they went out to our customers and they did a survey, and they took all age categories that go out and use technology and what they'd like to see. So as we flip through, and you can flip the slide, you will see immediately upon signing in to the website, which is excelisbcbs.com, you will see a member logon. Very user-friendly view. It's simply signing on and creating a passcode. And from there, what you have is a design directly to you. So it is a custom page back to you. And you can flip through the next slide. So the next slide you'll see kind of gives you a picture of what you will see. And it will say, "Welcome, Beth Miller." And it will have your name in the corner once you create that passcode. It allows you to work right within your own benefits. So you will see directly what's available to you. If you're on a metal level plan, you'll see that you have the Blue for You program. You can see who is on your plan. So it lists all the members. You can view your specific benefit summary. You can go into your claims. You can look for providers. You can also look right up for health preventions or anything there. You also have the option to make it available to have your monthly health statement actually emailed to you. So again, trying to save the paper and stuff coming in your front door and help you organize yourself, you have options. So I really, really encourage everyone, if you haven't already done so, is to get out on the new revised website and sign on. I think you will be very surprised.
So we're going to move to Megan, and I just want to say that Jim just came down and gave me a tutorial on the microphone. So other than Steve, who you can probably hear without, but he's still supposed to talk into a microphone, the rest of us should be about 4 or 5 inches away and have it facing directly towards us. All right?
Thanks,
Please,
Matt.
Megan.
So this is the ProAct website. We have actually, in the last year or so, we have revamped our website, and then in the next couple of months, we're going to be launching more features. So I'll just kind of talk high level right now of what we can mainly do on the ProAct website. So it's proactrx.com. You can log in and order new refills. You can connect to mail order and check on the status and the shipping of your prescription. You can ask for a refill. You can send a fax to your doctor and say, hey, I'm out of my prescription. I do need another refill. You can access our formulary. And then on the next page, it just kind of highlights the overview of what you're going to see when you order a refill. So it'll have your patient name, what medication, how many, what the dose is, and your dosage is, and your total cost. And so when you see your statement, you can see exactly what prescription was filled, how much it costs, and when it's going to be shipped to your house. So in the next couple of weeks, we're going to be launching our new website. We'll kind of go over more in detail about your benefit information and what's exactly covered. But for right now, you can certainly access the formulary to see what tier your prescription, what your copay is and what tier it is.
And something just from the clinical side to kind of piggyback off of what Megan has said, we're trying to expand our clinical presence on our website as well, so offer more patient resources, clinical resources, provider resources. And something in the pipeline is trying to change or streamline our PA process. So we will have custom forms available online, streamline the process from the provider and the member to get the information to us, review the claims, get quicker approvals or decisions. Also, when you create a member account, you sign up for a monthly newsletter, so a healthy newsletter that you can receive, and a few other things that are kind of in the pipeline that we're working on to expand our website. So
that's more to come in the next couple of months, and we also have the new app as well. So you can go online and access your ID cards and see when your prescriptions are going to be sent to your door.
Can you just expand on the PA, because some people may not know what that is. Some folks aren't as versed here as others. Just want to make sure they understand what that was.
So the PA process, specifically on specialty, which Steve kind of touched on, is the biggest growth factor in our industry. So the prior authorization process is basically a checklist or a guideline that we go through to make sure the correct medication is being used for the correct condition, and all of the lower treatment cost options have kind of been exhausted. So it's a clinical PA review process that is done by our clinical department. One of the things that I spend the majority of my day doing is reviewing prior authorization claims, making sure they're valid, making sure the diagnosis is correct and there are no other treatment options that are cheaper.
Thank you. I appreciate that. And now just reviewing the Consortium's website a little bit. We do have a really good website that the Consortium has. Michelle Potteroff is the person who's really responsible for making sure that this not only was set up, but keeps it updated. It's a fantastic job she's done on the website. Ton of information on there. You can see from the front page, there's a little welcome, mission statement. Our new logo is down there at the bottom. You can click on municipal membership and get a list of those entities that are involved in the program. On the left-hand side, in terms of that ribbon there on the left, a lot of information about the board of directors, agreements, meetings, et cetera, financial data, history of the consortium, really a wealth of information. If you ever want to know anything about the consortium, if you're new to it, or if you're new to one of the employers that are in the consortium, really a good place to go and get some of that background information about the consortium. In addition, there's a lot of links on there, both to Excelis's webpage and also PROACT's webpage. So certainly use that as a resource. There's some information in there on Medicare. Certainly a great place to start if you want to investigate what's going on with the consortium, or you don't remember what the link is to Excelis or PROACT. You can certainly go on there and get funneled right through.
Steve, I'd just like to add that today's video will be posted on the homepage, and it'll stay there for about a month. And then you can find it and all the previous retreats on the resource page. So they still are archived with the consortium website. And Beth, do you want to speak to the preventive?
Yep.
Thank you.
So we just went through 3 fantastic websites, and really the best thing that we're trying to portray here is the fact that this information is out there and available to you. Again, on our webpage, you can get specific information regarding preventative health. Lots of mandates passed, paid in full benefits for annual physicals, mammograms, things of that nature, but also some direct information regarding fitness or low back pain or weight management. Anything that you're kind of looking for is actually at your fingertips. The old scenario, let your fingertips do the walking. Well, now you go right through and you click through what you need. So by all means, if you take away today, bring to your membership that they have access to these websites also, and they should really take a quick look at them.
So we've been providing you with a number of places to grab information, but we'd really like to summarize what questions should I be asking. And so I think, Beth, you're going to start?
Yes. So unfortunately, I'm not sure where Ken is. I hope everything is okay. But he is our wellness coordinator who is on the Own Your Own committee. So right now, I'm going to go through some of the things that he has pulled together for the presentation. And one of our most utilized campaign right now is our Choosing Wisely. Steve went over the slide that was very busy about patients' choices, and you saw the beginning of the slide with the person with their hand on their head. Here we go. And what decisions to make. So really what has happened is we realize there's a lot of questions for members when they come into a provider. And what we've done is piggybacked with Consumer Reports, and they did an actual study between providers who also want to know what's going on with the patient. So there's a communication and dialogue that happens, and really this campaign puts that together. And what it's produced directed to is to actually have that meaningful discussion between you and your provider. You can just click the next page. This campaign is out on our website. We have information over at the table. During break, you can grab the information. But really, the 5 questions have been narrowed down through this campaign. And again, as Steve indicated, what is, do I really need this test or procedure? You know, does it make sense? Does the effect outweigh the risk? So what are the side effects? Is there a simple or safer option? Is there a behavior or modification that I can make versus going through surgery or starting a new drug therapy? What happens if I don't do anything? Is there an option? And then how much does it cost? And will my insurance pay for it? So a question that, sometimes gets left out of the discussion is, what is the cost? And what's my option if I don't do anything at this point? So good questions, good dialogue. Again, on the website, information's handed out at wellness fairs and everything. But make sure you're aware of these questions to have that important conversation with your provider.
Megan?
Yep, so just a couple of questions when you're going to the pharmacist and also to ask your doctor when he's writing the script for you. What tier is the medication being prescribed? Is it a generic? Is it a brand name medication? If the medication is a brand name, are there generic or therapeutic alternatives available? So if the medication is a brand, what is the cost to me? What is the cost to the consortium? Are there generics available? Is there a cheaper option? A lot of the times with brand medications, there are other alternatives available that might be more cost effective. Does this medication require a prior authorization? I know Austin talked a little bit about prior authorizations and all of the details and time that it takes to go through a prior authorization. What is my cheapest route to obtain this medication? What are the trade-offs and what are my options?
Something just to add from the clinical side here is, so you go into the doctor, what tier is the medication or is it a generic? If they say it is not generic and it's a brand, I don't want you to just stop there. I want you to consider, we call them therapeutic alternatives. Not true generics, but drugs that may be suitable to treat the same condition. That would be cheaper options. So I don't want you to just stop when they say there's no generics. Kind of push a little bit more and see if there are other alternatives that could be a cheaper option. There is not always a cheaper option. So just keep that in mind, but something that we definitely need to push more towards. And then I spoke a little bit about the PA process at the beginning. And basically the PA process is a type of cost containment strategy. So we build our prior authorization guidelines. Specific meds fall into that PA suite, and our pharmacy and therapeutics committee kind of review the guidelines from the doctor's side. We also have pharmacists on the committee that review the medications and also determine the therapeutic alternatives. So if there is no generic, what is the kind of lowest net cost therapeutic alternative? If there is no generic whatsoever, if there's no therapeutic alternative, if there's other steps that you kind of got to pass through to get to the approval for that drug. And what we're trying to do is prevent the high-cost drug being the first option. We want to go through the proper steps to get to that final, high-cost therapy. And then the route to obtain this medication. So typically, we would see this as our retail pharmacy, the mail order pharmacy, and then the specialty pharmacy. So our focus, a big focus now is adherence. So something that we definitely want to push on is kind of what Beth said. What are the repercussions if I do nothing? So from our pharmacy side, what are the repercussions if I'm not taking the medication that I'm prescribed at the right time or continuously, if I'm not taking all the medications that I'm supposed to be taking? And we focus most on adherence in the chronic disease states, so your hypertension, cholesterol, diabetes. All those disease states, if not managed properly, can progress. So if you don't take if you're not adherent to your medication and you're on a low-cost medication, that can lead you to progress to higher-cost medications. Diabetes, you progress to insulin or the higher-cost brand name drugs, rather than if you're compliant, change your diet, manage your other chronic disease states. So if you have diabetes, you want to make sure your blood pressure's under control, your cholesterol's under control. It'll decrease total cost expenditures. So just a little addition from the clinical side. That's kind of our thought process here. So.
Yeah, thank you, Austin. Just to wrap up this section, really, again, showing you where you have the information to go out at your fingertips. This slide just gives you a little bit deeper dive into the Choose Wisely campaign. Again, preventative measures are the best measures. When you do need to seek services, be ready, prepared with your questions to ask your provider. But the information is there, and like Austin said, we're looking for adherence and to do the health and wellness right steps.
All right, in our next section, we're going to start talking a little bit about managing costs, not only from a benefit perspective, but then Dr. Sloan's going to talk a little bit about how the physician community and the hospital community are also looking to manage costs and provide more efficient care to our members. So if you just look at the first slide, talking a little bit about benefit plan design. We've got a lot of different types of benefits throughout the consortium. A lot of these came from programs that were built long before the consortium was even thought about, especially the traditional health insurance plans, or what we refer to as indemnity. Indemnity plan simply refers to a program where a lot of the services, the hospital and medical surgical, are 100% paid. Then you have some things that fall under quote-unquote major medical, as we used to refer to it, where you're subject to a deductible and a co-insurance, and that's really limited to office visits, durable medical equipment, medical supplies, et cetera. Kind of an old school type of model for health insurance. Today, probably the most common program that's out there is a preferred provider organization plan, or a PPO plan. Quite frankly, most of the programs that we have through the consortium, whether they're traditional PPO plans or even the metal level plans, are really based on this modeling, this preferred provider organization type of program. We also have high deductible health plans. High deductible health plans are a very special category of plan that was developed when health savings accounts came along a few years ago. And basically, they have to have a minimum deductible level in order to be considered a high deductible health plan. Today, you have to have a minimum deductible of $1,300 for an individual, or $2,600 for a family. That is going up next year to $1,350 and $2,700. And if you have a high deductible health plan, then you get the opportunity to open up a health savings account and take advantage of putting some monies away, having those deducted from your taxes, and you can pay for unreimbursed medical expenses out of that health savings account. Then we have our metal level plans, as we refer to them. These are programs that we built based off of the modeling from the Affordable Care Act. They're set at a different level of actuarial value, and that actuarial value really relates to the percentage of the cost of care that the average member can expect the insurance plan to pay versus them paying. So as an example, and we'll go through it in a little bit more detail in a bit here, but a platinum plan would pay 90%, and the member would pick up 10% of the cost of care. Subscriber share of costs, obviously that's a component that's been used in health plans over the years for two purposes. One, to share the expense, so that the member or the patient is picking up some of the cost of care, which helps keep the premium a little bit lower. And then secondarily, to try to engage the consumer back into the process. You know, when things were predominantly paid 100% by the insurance carriers, members or patients had very little incentive to start asking questions when they went for service. Well, now all of a sudden, if I'm paying 20% or if I'm paying a copay for certain services, now maybe I'm asking some more questions. So certainly the subscriber share of costs is a big component of the benefit plan, excuse me, which helps us keep the premium low, but also helps engage that consumer into that process. Looking at the difference between an indemnity plan and a PPO plan, just to give you some basics. Again, the PPO plan is pretty simple. As long as you stay with a provider that's considered in-network, and we'll go over that definition in a second, you're basically going to pay a copay for service. Under the indemnity plan, you've got that upfront deductible, and then you're paying a percentage of cost of care, a little bit different modeling. In the end, you know, when you look at a $100 deductible and an 80-20% program in a traditional model versus like a $10 PPO, quite frankly, there's not that much of a cost difference on the medical plan perspective. It's just a different way of structuring it so that members are more encouraged to stay in network when they can for services. Excuse me. Giving you the definition of the metal level plans, again, we talked a little bit about what the actuarial value meant. And again, it means basically the percentage of an average person's cost of care that the plan is expected to pick up for them in a given year. So a platinum plan has an actuarial value of 90%. A gold plan has an actuarial value of 80. Silver is at 70, and bronze is at 60. Bronze is the lowest level benefit plan that an employer can offer and stay within the mandate of the ACA in terms of providing credible coverage. Obviously, the premium is a lot lower with the bronze plan. Most of the programs that we have with the smaller employers in the consortium are either platinum, gold, or silver. They look a lot like a PPO-style program. Some of them are considered high-deductible health plans, for instance. Currently, our gold, our silver, and our bronze are all three high-deductible health plans and do have health savings accounts attached to them in terms of available benefit to members. In terms of how we maintain the plan's actuarial value from year to year, obviously that's a moving target. As costs go up, members' cost share needs to increase proportionally with the plan cost to maintain that relationship, either the 90, the 80, the 70, or 60. There is a standard deviation built in of plus or minus 2%, so it's really a window for platinum from 88 to 92%. But basically what we're doing each year is we're going through and evaluating the actuarial value using the Medicare actuarial value calculator. As long as we stay within the range, we don't have to make any benefit changes. If it goes outside the range, we would work with the Joint Committee on Plan Structure and Design and come up with what the elements of change would be to get it back in within the definition of the actuarial value for that particular plan. So we do have a process in place, and last year was the first year we went through that. We did have some benefit changes that went into effect January 1st. The bad news about that is some people had to pay a little bit more out of pocket for service. The good news is with most of the programs, with all the programs, the rate of increase was less than it was for the traditional plans through the consortium, and in some cases, it was actually a reduction in rate. So From that perspective, members did receive a little bit of a positive impact from a premium cost share perspective. In terms of defining in-network versus out-of-network, it's pretty simple. An in-network provider in this case is going to be either a medical provider or a pharmacy that either has a contract with Excelis or ProAct to accept a particular fee for services that they provide. And it's pretty straightforward. If they're out-of-network, they're considered to have no contract with either one of these entities. Now, to take it a step further, with Excelis, it goes just beyond Excelis, Blue Cross Blue Shield in terms of the medical network. We actually have access to the entire Blue Cross Blue Shield network, both national and international. So all the Blue Cross Blue Shield plans throughout the country, we have access to their networks as well. ProAct, they're a national PBM that offers a pretty broad spectrum of pharmacies, so that covers the entire nation. Excelis, by their structure, is really more of a central New York kind of company, but because of that linkage to the other Blue Cross Blue Shield plans, we have access to that wealth of provider database that all the Blue Cross Blue Shield plans enjoy, and that certainly helps our members that are either retired, living out of area. You know, we got kids that go away to school, and we've got obviously members that are traveling either for work or for pleasure outside the area and sometimes do need to seek care as a result of that. Obviously, we gear all the benefit plans and we do all of our encouragement to keep people in network as much as possible, but we also want people to know that they can get care from whatever provider they feel is appropriate, and they'll still have coverage within the consortium. Excuse me. Within provider networks, just talking a little bit more about how it works and, you know, the relationship. Obviously, healthcare services covered by a benefit plan need to have these provider networks available. Otherwise, you're going to the physician's office, you have no idea what it's going to cost. You have no protections. We want to make sure that those protections are maintained. Health insurance administrators and prescription benefit managers, obviously they need to contract with physicians and hospitals and pharmacies so that they have a product that they can offer to folks. And the consortium contracts, obviously, through those organizations so that we have access to the provider contracts that they've developed. In terms of discounting, you know, the question always comes up, well, is it meaningful to have, you know, these networks and the discounting, et cetera? Clearly from the data that Excelis provided relative to billed provider charges versus what's ultimately paid, prior year was about 43%, this year was about 48%. The data goes from October 1st, 2015, September 30th, 2016, with payments through the end of December, so it's kind of an incurred and paid look. But certainly the discounts are substantial in talking about the cost of care. In terms of the medical service area, in terms of the provider network, just looking at the Excelis provider network schematic, if you will, they've got over 28,000 physicians through their region. And again, you can see the region is pretty much, you know, central New York, southern tier, and then the northern portions of the state. And they also have 80 hospitals under contract, and I believe the 80 hospitals is all the hospitals in that service area. And the 28,000 providers is 97% of the provider base in that service area as well. In terms of the ProAct pharmacy network, at last count they had about 67,000 different pharmacies, locations all across the United States and even some outside the United States. All of the prescriptions that are filled and paid through the consortium are in-network. Most of our programs don't have an out-of-network benefit. So certainly finding a participating pharmacy with ProAct is important, but certainly with this breadth of depth in terms of pharmacies, it's pretty easy to get to a participating provider from a pharmacy perspective. Covered member choices in terms of how it affects out-of-pocket costs. Obviously, we've talked about some of these already. Just a recap, you know, where you seek out your care in terms of the provider that you see or the treatment center you go to, what tier your prescription drug falls in, and whether or not there are alternatives that you may be able to seek out, the staying in network versus going out of network, Obviously, seeking out the preventive care to get early diagnosis of issues that may come up, and then obviously lifestyle changes. And this is something that everybody is harping on in terms of us being able to do more to stay healthier, to live longer, and to keep the costs down. Now, with that, I will turn it over to Dr. Stallone to go through some information about the Cayuga Area Plan, which is the Cayuga Area Physicians and Cayuga Area Medical Center.
So before Dr. Stallone starts, we're a little bit ahead of schedule because you haven't been asking questions. So Steve and I are like Energizer bunnies, and we just get started, and we don't stop. Any questions on what we've covered so far? Please, Beth.
With regard to the prior authorization process that the pharmacy uses, how do you communicate that decision to the prescriber and to the patient? If you come up with therapeutic alternatives, do you actually let the prescriber know what those are?
Yes, so we're in direct communication back and
Please,
forth.
use the Austin.
Use the.
Sorry about that.
You have to talk to Jim.
All right. So our process has a standard where we're in direct communication back and forth with the prescriber. So if we get clinical notes and we're missing a piece or two, we send a fax or reach out to the doctor via phone, get the information, complete our review. Once a decision is made, the prescriber is notified, and we notify the pharmacy to process the claim. That's an approval. If it's a denial, the doctor and the patient will receive a denial letter with kind of justification or rationale behind our decision. And with that, the member always has the option of doing an internal appeal, so it's reviewed by another. So we have clinical pharmacists and our whole team to review it. So that's taken care of by somebody that was not involved in the original approval or denial. And then there's also the third step where you get denied on the original appeal, you get denied on the internal appeal, and they can request an external appeal, which is sent to an external company that is we send it to a board-certified physician in whatever specialty that the drug falls into, and they review it, and their decision is also taken into account. So,
Thank you. One other question. With regard to the in-network piece of the consortium's plans, if a person is out of network but within the Excelis, sort of in that Blue Cross Blue Shield national participating group, is the patient paying the in-network share, or is the patient paying the out-of-network share?
It would actually, Bev, depend on the specific product.
Mm-hmm.
However, the majority of our out-of-network benefits pay according to in-network. So they would be responsible for the difference of the charge between the in-network payment and the charge of the out-of-network provider.
So they
Plus
have
any
a pretty large network then, when you think about it that way.
Correct. Any deductibles, co-insurance, or co-payments would also apply.
Thank you.
Yep.
Don, can I follow up on that question?
Of course, please.
Beth, can you explain the process of somebody doing an out-of-network, say they go out-of-network for surgery or something to that effect? How does the bill get processed, and what happens with the employee or the patient's payment?
Okay. So typically, if a provider is non-participating, some will bill the Blue Cross Blue Shield local plan to get the claim moving. Others will simply request payment upon services. So they're providing a service and they're expecting payment when the service is rendered. And then it would be up to the member to submit the claim to us directly. There are claim forms that the member can download off of our website, or they can call into customer service and request a claim. The bill that they had services rendered would need to be on a physician or hospital bill that includes procedure codes, diagnosis codes, and the cost of the care, so that we can review that.
And the check is sent to the patient?
Correct.
And they're
Correct.
responsible for paying the provider?
Correct. It would be, then the claim becomes between Excelis and the member. So the payment would go back to the member. They would be responsible to pay the provider in any differences between our allowance and our payment to the member and the charge.
Okay.
Okay?
Thank you. I'm not sure people always understand that, and they get a check from Excelis and go, woo-hoo.
Yay, free money.
Until they get the bill from the provider.
Yeah.
So.
It is something that if and when we do have an out-of-network claim payment, if it's a large amount, anyone should always be going, I'm pretty sure Excelis isn't just giving me a check for being a good patient. So they should be calling into customer service and saying, hey, I have this check.
Yeah. And a follow-up question on the prior authorization. What's happening with the patient during this time process that is going through the prior authorization? Because are they standing at the pharmacy? Or what's happening with them?
So typically, we pride ourselves on turnaround time. So 48 to 72 hours, once we receive all the information from the doctor, we will have our decision, one way or the other, denial or approval. If it goes, so our process goes, we request the information. If we don't get the information requested from the doctor, we reach out again. And on the third time, we send a letter to the member. So we try to get them involved in the process. So if the process is taking too long, if we get the member involved and the member's calling the doctor instead of us, sometimes it gets things moved along. And we also, any questions or issues, I have members calling the help desk every day, our ProAct help desk, and we can communicate between the clinical department and the help desk or transfer the call to the clinical department and kind of let them know where it is in the process and try to speed things up as best as we can.
Do you have any idea how often it is that the patient is going to the pharmacy to get the prescription and that's when they're finding out that it needs prior authorization?
So typically that would be in a new therapy. We also have a process in place where if it's a continuation of therapy, so the member's been on that medication, we confirm it with the doctor or the pharmacy. We allow a one-time override and start our PA process. So we don't want to disrupt therapy. So we also have that piece in there too. But is your question asking
I can add in just on that, electronic prescribing helps a lot with that, just in actual practice, where it used to be that people brought a piece of paper to the pharmacist, and we're getting calls. So in the case of hospital medicine, which is where I come from, before the patient actually leaves the hospital, we're getting calls if there's an issue. So for what it's worth, that helps.
Yep. And another piece, kind of just to add on to that, our website has the member formulary version, which is we try to put the most common medications on there, but not every single medication is included. And I urge to use the resources of calling our help desk. They will navigate through the entire formulary. They can tell you what restrictions apply.
I can just tell you from a benefits administrator, their first call at the pharmacy is to us.
It's to you, okay, yeah.
Why aren't I getting my medicine? So, and then we have to try to figure out, if it's got to go through prior authorization, you got to talk to your doctor.
Exactly, yep.
All right, thank you for those questions. I had clarity. We have another one. Ted, quick question? Please. Yeah, we have to stay on time.
So I was just wondering, with the Excelis website, are you going to be, is an individual going to be able to go on that site and find out this information about their personal situation? So how deep is it for being able to retrieve your own information, like the statements that you get monthly or you may get monthly, and therefore maybe be able to access the kind of information that Judy was talking about too, about in-network, out-of-network options?
Yes. All of the above. So on our website, once you sign on and create an account, you have access to all of your claims. So all of your past history, any authorizations for services that might be required on a PPO plan, they are also listed there. There's access to our provider network. So looking for a doctor, looking for a specific doctor in a certain field, you have access to that. It also brings you out to our Blue Card program. So if you're traveling and you just want to make sure that you know who the participating providers or hospitals within any given area where you're at, or if you have a college student, you would have that also at your fingertips.
Can I just add one more thing? You can also, this is Ken with Excelis, you can have your card, your medical card now virtually on your phone or tablet or anywhere, so you can show that, which is another new benefit as well.
All right, thanks for all that extra color. We're honored to have Dr. Marty Stallone here from the Cayuga Area Plan to talk about what the physicians are doing to help manage cost.
Super. Thank you, Don. I'd like to just start by thanking you all for the opportunity to talk with you. And I think that when we usually approach a community to talk about healthcare reform and how we're acting, we have to start with the backdrop. And so it's actually nice that you went through all those what amount to imperatives for change. And perhaps my main message is that the provider network here in town, which I want to talk with you more about and tell you about CAP and what we're doing, is nicely positioned to cooperate with all these efforts. And I'd be remiss by also saying that Blue Cross is, Excelis in particular, is an excellent partner. And in fact, later on today, we have an Aqua working group where Blue Cross and CAP meet and communicate a lot of the information that we talked about and align the providers so that we're really thinking about the issues that you spoke about here today. And that this is not new to the provider community here. We can't say that for all communities in the United States. I think we're lucky to have a cohesive provider community that values these issues. And we actually do this. We manifest our mission through what we call our clinical integration program. And when I say provider community, I mean the local hospital, the single hospital in the county, and all of the providers. So we're very intent, and we feel like we're in this with you to get cost and quality under control and achieve what we all know is the triple aim. So good quality, controlled costs per patient, but also good population parameters, that we're actually not missing the forest for the trees, that we're not kind of overlooking an emergent property of healthcare that's really afflicted the whole country, whereas you can actually have good point-to-point quality but have costs at the macro level spiral out of control. So that is to just say that I think CAP and Blue Cross, in conjunction with important purchasers of care like TCOG and the Health Consortium, are a good team. I would say just one plug for an event is the Community Healthcare Forum CAP is putting on next Tuesday. If you're interested, there's a flyer advertising it, but we do reach out ourselves, and it's at Green Star, so next Wednesday, 1 week from today at 5:30, and if anyone would like to come, there's RSVP information in this flyer, which we can kind of leave over there, so you're all welcome. Slide. It's okay. Let me just start by just explaining what CAP is. CAP is a singular organization, but it's co-owned by Cayuga Medical Center and Cayuga Area Physicians Alliance. And Cayuga Area Physicians Alliance, we quickly call CAP-A, is the physician side of the equation. Those are the individuals that really direct all the care. The hospital renders care, but behind the hospital rendering facility care and at all its locations is the physicians who interface with the patients and direct care. So CMC and CAP-A co-own CAP, and CAP engages with a number of different insurance companies, including Excelis, and we form contracts around care being provided. But part of those contracts is the provisioning for cost and quality in a way that really is atypical for contracts of the past. So CAP runs a clinical integration program. So CAP is a company that's co-owned by all the providers in town, and we run a clinical integration program that basically maintains physician and hospital activities around controlling costs of care and ensuring the quality of care. And we pay attention to how we do on the population level. Again, it's not just individual patients getting the right thing. We worry about that certainly, but then at the end of the day, we make sure that our populations, which are largely payer-defined, are treated in the right way. And I put a little map up there just to say that we are centered around Ithaca, and we provide the vast majority of care to residents of Tompkins County compared to any other non-CAP provider. And we do have a presence in the adjacent counties, but we like to consider ourselves the home team. Our vision is that we're your provider of choice, and we know to be that in the future, we not only have to provide excellent care, but we have to provide cost-effective care as well. So moving on, our mission isn't too dissimilar to yours earlier in the presentation. And it's not too dissimilar to Excelis's mission. I mean, we're all in this game to achieve high-quality, cost-accountable care for the population that we serve, and we do this through our CI program. So next slide. And we, again, define populations. So you are all in our Blue Cross population of patients. You're all, or you have the potential to be attributed to CAP by your primary care doctor. So to start with, if you see a CAP primary care provider, one of 10 practices in town, you get labeled a CAP provider, and basically we worry about the total cost of your care. And things like pre-authorizations and questions like that, we're actually treated a little bit differently because we're accountable to the total cost of your care. We have skin in the game. And we also get reports on how we do for our attributed population, which is around 20,000 Blue Cross members, on population statistics. So how are we doing with diabetics across that population? How are we doing with hypertension control? Hospital readmission rates, high-cost imaging, et cetera, et cetera. Choosing wisely campaigns, how many of the things that choosing wisely tells us not to do are we doing by provider? And then people like me and CAP go to the providers and let them know. So we really organize ourselves to get information from purchasers and payers and bring them into the practices so that we do better. That's the essence of this. Slide. And we orchestrate different aspects of care. So again, if you go back to CAP being an organization that serves its members, we use fairly sophisticated data and analytics, and we take in data that we get from partners like Blue Cross, and we direct care. We tell providers which of their patients haven't done things they should do, and when they need to do things that they haven't done. And then we have Ms. Emily Maller, to my right, is the lead nurse of a growing group of nurses who actually go into the community and track patients that the clinical integration program, in partnership with Excelis, identify as having needs or in some way at risk. And it could be as simple as they haven't done something, or it could be as complicated as they are a high-cost claimant and they are bumping around the healthcare system and they need some help. And the important thing is they need help in ways that the traditional healthcare system isn't organized to provide. So they really need an inter-organizational advocate, and CAP provides that. And so Emily does a great job with those nurses that work on behalf of the practices to guide them through the system and avert issues. And we have some really, I don't want to steal the thunder for next Tuesday, but next Wednesday, but we have some amazing success stories of patients who were truly high utilizers of care, like dozens of ED visits per month that the CAP care management team accessed, and through very out-of-the-box solutions solved. Now those patients, those set of patients are not bumping around the emergency room. They're actually getting care in the right location at a fraction of their original cost. So care management. And then we also employ people who support practices. Sometimes practices don't know how they need to act in the system. So we employ people to go into practices and say, you need to record this information here, you need to reach out to those patients, and because we are CAP, they accept us going into their practices in their EMRs and guiding them. And then finally, this is one of the best secrets, is we coordinate the coordinator of the CATs, right? It's hurting cats to coordinate a physician network, but we actually coordinate the managers of these practices. So we communicate very clear, singular instructions that the managers communicate into their practices. So again, CAP is a coordinating entity. And it's all in support of everything you guys talked about up until now to kind of bend the cost curve. I see a question on the right.
How large is the staff of the CAP?
It's in the 20s at this point. There's 5 nurses. There's a team that manages a data repository of about 5. I'm the only physician on the team, and we have a team of about 4 practice support specialists, and then we have business analysts and other support staff. So we're around 20 individuals.
And where does your revenue come from?
Complicated questions. It depends on different payers, and there's mechanisms through the contract to have money, I might use a bad word here, but carved out. There's earmarked money, and we also have a mechanism of taxing the physician network. So there's some revenues that can come actually from practices. some of our discretionary revenue comes from a concept of shared savings. So I'll get to the point where we're accountable to a budget, and the budget is a favorable budget. And if we actually beat the budget, some of our payment, and we call this value-based payment, is based on actually beating a budget. So there's multiple different kinds of revenues that support CAP. And you might think of CAP as a coordinating department. If we were one organization, and we're not, so we're like 50 independent organizations, if there was one big Mayo Clinic, inside of that Mayo Clinic type organization would be a coordinating entity. And oftentimes it doesn't exist. But CAP plays either, I mean, it's an discrete organization, but you could argue it plays a coordinating role the way an integrating department would in a complicated organization.
So your CAP process is kind of unique? It's not in every county or every...
No, not at all. So this is a PHO model. We are very unique. This is actually a special attribute of Ithaca, and I would argue for our size, we are one of the more diverse networks anywhere. Now, there are other regional networks. There's networks in Rochester and things like that, but in terms of the coordination of heterogeneous entities, is this working? I would say CAP has the greatest variability to coordinate. The greatest number of EMRs per doctor, the greatest number of organizations per attributed patient. We pull together a lot of independent organizations, and that's no small task. And that's keeping with the spirit of Ithaca in some ways, I think.
Thank you.
Okay, slide. Bottom line is we are accountable to a budget. We measure total cost, so we know for our attributed patients, like what is the per member per month cost, and we get a cost for the next period, what they should be. So when I saw your budgeted numbers, they are in keeping with the budget that Blue Cross gives us for our very large population. That's another way of saying CAP is accountable. So we try to grow. I mean, the budget allows for growth, but it's responsible growth. It's growth less than comparator groups. So when you saw those columns, I forget what slide it was, I mean, we have a budget that we try to accomplish that for you. I'd like to think that part of the success you've enjoyed is because of CAP's effort in this space, although you might not have been explicitly aware of it. But we actually have physicians who, in our network, who are cost conscious about the care that they're rendering, and we have these open discussions. So it's a little bit of a new day for healthcare in Tompkins County. Slide. This is a fact I never lose the opportunity to pound on, is that the total cost is really not about unit price. In healthcare, it's more about how many units of service we're talking about. So if you can actually maintain prices, that is not, it's not to say it's not correlated, but it's not the complete story. So you can have higher local prices and lower total cost. That is possible in healthcare because healthcare is mostly driven by utilization. So again, I compliment Blue Cross because they really do focus on the total cost side, not so much the prices. So that makes them a workable partner. Not all insurance companies are like that. Slide. And this is our, sorry if this didn't come out perfect, but we have experience from when we started operating as a clinically integrated network that we have grown slower than our comparator groups. So that top line is our comparator group, our budget, and we've grown at a rate slower than our comparator groups. And the space in between is savings. And I would say that this is net of all costs, revenues needed by the program. And the other thing I point out on this slide is that we're at risk. So if this doesn't project perfectly, but our line was the lower line. If our line was above the other line, we actually pay for part of that loss. So that's what's called accountability in healthcare. So it's not full indemnity, but there's accountability to a budget. And it's just enough, in my opinion, to be reasonable. I mean, there's all sorts of questions that can come off of budget-based network operations, and this isn't the time to go into the philosophy of it, but I think that Blue Cross does it well, and CAP's happy with that arrangement. Slide. We also measure total quality. I just mentioned, you know, we focus on individual encounters, but we also track, hey, how is our stat on the population level? Again, I mentioned some of these considerations. How are we doing with hospitalization rates? How are we doing with avoidable outcomes? How are we doing with compliance, and so on and so forth? And a lot of the information, our results actually are given by the payer in a lot of situations. Slide. This is just our good performance in 2 high-profile areas, breast cancer screening and colorectal cancer screening, and we just had colorectal cancer screening month recently that we celebrated, and we locally have exceeded the 80% by 2018 campaign, and regardless of how you slice it, whether it be by specific employer groups like CMC, and we do serve internally our own patient population, our own employed population, or all CAP statistics, we've actually beaten national standards by a lot. So we track this and we try to do better, and even though we started out largely because of our very good GI group and primary care community, we grew, and that growth in quality compliance is incremental patients. Those are human beings in our community who got screening, who wouldn't have gotten screening if we stayed at our 2013 levels. And you can calculate lives saved from that. So I think CAP works on the margin, and we track population performance, and we do it at the same time we're tracking our budget. Slide. And takeaway points. This is mainly just to affirm what you're working on. We're working on the same thing. CAP is on your side with this, and we hope that as we continue to mature the CI program, the Clinical Integration Program, CAP will continue to be your provider of choice, and that is probably CAP's ulterior motive in this, is that actually when we reach our vision of being a lower cost, higher quality provider group, that we can start the conversation of, well, you know, how do we incentivize, how do we convince more and more patients to utilize CAP services because they're accountable, because they're responsible. So I think in this paradigm, our interests are aligned. And I'm not used to going this long without any questions. I thank you for your questions, and if anybody else has any, I'd feel free to, I'm happy to try to tackle them.
Also, Dr. Stallone is going to stay here for our break in case you have a personal question you want to ask him, or maybe a broader question. So with that, let's reconvene here at 10 of. And get a stretch, get a coffee, and use the bathroom. Thank you. Well, it's good to see a group that's so engaged and excited about everything you've heard this morning, and now you regenerate your energy for the rest of the morning. We'll be done about 11:30. Gives us about 45 minutes to finish this up, and we're going to start with our utilization reports and then the trends coming forward. So I turn it over to Beth.
Thanks, Don. I appreciate it. Recently, we just went over the entire utilization management report for 2016. We do that at the joint committee meeting, and then we do a high-level executive summary at the board meeting later this month. So what I've done for this retreat is just simply take the high-level information and kind of go over it. Again, Dr. Stallone talked about utilization and the management and cost drivers. So as we talk about this, you know, you can think about some of what he had put together and how we are coordinating the efforts to lower that or bend that cost curve. High-level financial measures, simply that you had a growth in membership of about 1%. We had a few municipalities come on for 2016. 2017, we had 8 new towns and villages join the consortium, so we're now up to 28. That's a big bump that we'll see in next year's utilization numbers. However, in 2015, we had a fabulous year. We had lower cost claims. And then in 2016, we kind of moved back up to our normal trend line. So we had an increase from 2015 to 2016 of about 13%. One thing to point out between your consortium population versus our comparison population, we have a higher average age and a lower member cost share. Two things that stand out from the comparison. And what I mean by lower member cost share, so when a member actually goes to utilize services, they pay a lower amount out of their pocket, so co-payments or co-insurance, deductibles, that actually represent from the comparison. The last point to make is very good news. So over the past 5 years, the medical plan cost per member increased approximately 4%, which is much lower than the actual healthcare trends of 7 and 8%. And again, the full utilization management report is out on the website, the Greater Tompkins Consortium website. So the next piece of the utilization talks about cost, claimed cost, and we drill into some of this with the membership has accessed 90% in 2016. That means 90% of the membership actually had one type of service hit into our system, compared to the 2015 with 84%. The next thing you'll see is the 80-20 rule, where you have 80% of the costs are driven by 20% of the membership. That is kind of a standard rule of thumb. However, when we take a look into that, we realize that in 2016, we had 25 claimants over $100,000 compared to only 17 in 2015. So again, 2015 being that year that was incredible lottery winning year, so to say, where claims were actually trending much lower than our normal trend line. The number of claimants over the 150,000 has fluctuated, so we actually took a look back a couple of years. So in 2014, you had 10 claimants. In 2015, it actually went down to 6 claimants over the 150, and then back up in 2016 of 10 members. So again, you can see how claims can fluctuate year to year. When the consortium actually takes a look at budgeting, it's a big decision that there's a lot of weigh in, not just looking at 1 year, but as a trend as a whole. And
Beth,
then-
Beth, sorry.
Yep.
I noticed that first number, 84% to 90%. Is that just, so, and you're saying all of this is just random between years, or is there a reason?
Correct. I mean, what happens is from year to year, a person may seek services or may not. The big thing is to look at the preventative care. We want to make sure people are doing those preventative measures. A lot of the preventative measures are sometimes every other year or every 5 years or every 10 years, depending on the type of service. So some people may never utilize care for a whole year, where others may utilize it more frequently.
I don't know if you might
didn't say anything important. I don't know if I project.
Talk about the risk pool?
No. I didn't do that.
Test.
You mean I have to repeat all this intelligence again? Thank you, Steve. Could you do that
No
for me?
problem. I think what Mac is trying to say is that when we started the consortium, we started with 2 large municipalities, the county and the city, and a number of smaller towns and villages within Tompkins County. Then the city of Cortland looked to join another larger entity, kind of thought about broadening out the scope of the consortium, and now we're in the not only Tompkins County, but in the 5 or 6 contiguous counties to Tompkins. And it seems like a lot of our interest that's coming into the consortium is from smaller municipalities, certainly less than 100 employees, many of which are less than even 30 employees. And the question is whether or not that trend could end up skewing our risk dynamic to some extent. That we're going to be taking on smaller populations, maybe with a little bit higher risk factor than what we've seen in the past. It is something we're keeping an eye on. I've not noticed it yet, but it certainly wouldn't hurt us to find another large employer or 2 to add to the equation as well. Certainly with the larger employers, you're getting a much more diverse demographic population, lots of different variables in age, sex, health status, et cetera, which helps us broaden our risk pool out a little bit. Sometimes with the smaller towns and villages, you tend to get a little bit of an aging population, smaller employee bases, retirees, and that can put a little bit of pressure on the risk pool. So I guess the short answer to the long description is yes, we're concerned that adding only small municipalities could ultimately skew our risk pool dynamic to some degree, and we are interested in talking to some of those larger employers.
Thank you. Beth.
Any other questions? Okay, so let me just run over the claim utilization high level. One thing to point again, 2015 was an incredible year. When we take a look at 2016, we had 58 more admissions than we did in 2015. The one thing to know is the average length of the hospital stay actually decreased. However, we had a higher number of admissions with a shorter stay. Talks about where the services were rendered, but the one thing to bring up the conversation of 2016 going into 2017, again, we had the increased member cost share that moves over to the metal level plans, which will reduce future costs going into 2017. We hope with some of these plan design changes that are becoming more popular. I'll turn it over to Megan.
Okay, just some of the highlights from the 2016 utilization review. Mostly we talked about the specialty utilization. So I'll end with that at the end here. But 82% of the scripts that were filled were generic, which totaled to about 2.2 million, leaving 18% brand name medications. Brand name medications are made up of your tier 1 and tier 2. Those are the more costly of the medications are your tier 3. And then leading into specialty is where majority of the plan spend was. We had a large population, a large number of Harvoni claims, and Harvoni is used for hepatitis. I'll let Austin speak to that in a minute. 1% of the scripts that were filled attributed to 34% of the plan spend for 2016. And from 2015 to 2016, we saw a 53% increase in your plan costs just in specialty. So it went from 2.4 million to 3.6 million, okay? And largely, this was due to the hepatitis medication Harvoni.
Kind of just to piggyback on what Megan highlighted is Harvoni is a new treatment category or a category of drugs that is basically a cure. So 97 to 99% cure rate for hepatitis C. So hepatitis is a chronic disease, a progressive chronic disease. So I feel like with this medication, it's typically a 12-week therapy, and that member is now in basically remission or cured. So obviously 2016, the cost increased. Each one of those fills results in a $32,000 charge. That's the cost for 1 month. So if you extrapolate that over 12 weeks, over $90,000 for one member. But something we have to keep in mind is as this drug is a cure, they're going to have yet less utilization on the medical side, less utilization on the prescription side, equaling a more healthy total population. So huge hit up front, hopefully long term, you'll see the decrease. So maybe 2017, as long as we don't get any new Harvoni claims, I think you should see a significant decrease for sure.
Austin, do you have any dollar equivalent, or Dr. Sloan, on if they didn't get Harvoni, how much it would cost and other medical costs down the road?
I unfortunately don't have specifics. It's something that it's a newer class of medication, so the long-term studies really haven't been taken care of, but maybe Dr. Stallone will have some
I can just share that, I mean, the natural history of the disease is cirrhosis, and a subset of people with cirrhosis, if early enough and if qualifying, are the transplant candidates. So one, they're complicated hospitalizations when they happen. So those hospitalizations are tens of thousands of dollars, and they can happen recurrently with ascites and things like that. And then the transplants, those are on the list of people in that top few rows those are $500,000 cases. I mean, those are, so now how many of those treated avert how many transplants? That would be medical economics. I'd look to the pharmaceutical company. I'm sure they priced it off of that, but those are substantial cases, are cirrhosis-related liver transplant and hepatic encephalopathy cases.
So I'm going to assume that this drug is not one that's, I mean, it's prior authorization, but we're not trying to get them off from this onto something else, because it sounds like this is a much better option.
100% correct. So in our guidelines, you have to have certain criteria. Chronic hepatitis C, your viral load has to meet certain requirements. Testing, laboratory testing to confirm all of this. So we're not, I feel like sometimes people think that we push drugs, but our PA process is there to limit and make sure the drugs are valid. So, and also we take into account all the new studies. There's new studies out that are showing that people with certain viral loads, lower viral loads without cirrhosis, can be cured with 8 weeks of treatment instead of 12. So in our process, we've incorporated that, and we push back to the prescriber to see if that's agreeable. And then at the 8-week point, they test the viral load, and if they have a sustained virologic response below the threshold, they're considered cured. So we just saved $32,000. Yeah.
So next we have the CanaRx program. This will be available to all of the consortium members starting July 1st. Right now we are working with I'm working with Don and the executive team to come up with some letters that are going to be sent out to the consortium from the consortium and also from PROACT as well. This program offers over 500 brand name, some maintenance and some specialty medications. A couple of excluded medications from the formulary and the program are narcotics, antibiotics, lifestyle medications, and temperature sensitive. So what that means is that the CanaRx program is an international drug program that is voluntary for all members. So if you are on a maintenance brand name medication, and you're taking one of the 500 brand name medications on the formulary, you are eligible to participate in the program. Some of the cost benefits that are available to the members are a $0 copay, and also the medications are much cheaper for the consortium as well. So that's coming for July 1st, and expect to see some letters coming out that explains the programs, how to enroll, the formulary, and some of the benefits.
So we will be introducing this to our benefit managers this coming Tuesday, so all the municipalities will be aware of this program. And then later this month, we'll be sending out through the consortium a letter to all the subscribers within the consortium about this opportunity. And then early June, there'll be actually a communication from PROACT to the subscribers that actually have a prescription that could qualify for CanaRx. Then they'll be approached directly by PROACT to see if they're interested in joining. So that's our plan going forward. Thanks, Megan.
So next we have some of the prescription therapy programs. I know we've already talked a lot about prior authorizations, but I'll let Austin talk about step therapy.
Yeah, so we're kind of our cost containment strategies from the prescription side. So we require step therapy, which is also kind of built into the prior authorization process. PA kind of encompasses all the strategies we have to contain costs. So within the prior authorization review process, we integrate the step therapy. So if we get a drug, our biggest category right now is the diabetic category. So like certain drugs to treat diabetes, there are 9 available brand name products, no true generics. What we do is we sit back and we look at all the 9 products. Is there differences between them? Is one more effective than the other? and then we prefer one, so that goes back to our tiering structure. Tier 2 brands versus Tier 3. We try to get those Tier 2 lowest net cost drugs approved first, lowering total cost for the plan. And again, we kind of touched on the PA process. It's a hard process to explain because it's variable across different drug categories and constantly changing as our drugs that are available to the market keep increasing, and new generic launches, and then we have to reevaluate everything at that point. And something else that we, and specifically to your plan, we try to implement this across our book of business, is a max dollar amount. So if we see a claim at retail, so when you go to your local pharmacy, retail pharmacy, above $1,500 for a 30-day supply, that would trigger a review. So a PA review would be triggered on anything above $1,500 for a 30-day supply. To go on top of that, mail order, so if you're filling 90-day supplies, we step that 3 times to the $4,500 max. So anything above that would trigger a review. Just kind of another, making sure drugs aren't sneaking through rather than sneaking through our PA process or sneaking under restrictions. We definitely see some definite benefit from that. And we already touched on it, but all specialty medications, as that's we see our biggest increase year over year in specialty just because of the cost. All specialty medications would fall into that PA review process.
We have a question coming up.
I have a question. Thanks. I have a question regarding the step therapy, how that plays out in terms of the patient. Are the doctors aware of this? Or like if I go, I get a prescription and say it's not one of the preferred medications, I go to my pharmacy, what happens at that point?
So again, we kind of have policies and procedures built into place. If it's a medication that you've been on, we will allow a one-time override, review the process, make sure. Typically, doctors will go through the proper steps. In my mind, I feel like doctors won't try to prescribe that ultimately high-cost drug if there's other alternatives available. So we have a process in place that if you go to the pharmacy, you've been on the drug, we confirm it, we do a one-time override, kind of go through the PA process to make sure those cheaper alternatives have been exhausted. If not, we communicate with the doctor, see if it's in your best interest to pursue one of those medications. And all of this it's not a strict guideline. We take our clinical judgment and we try to have common sense play into this as well. So the step therapy program is basically trying to get the lowest net cost alternative filled. If you go to the pharmacy and it's a new therapy, you'll get a rejection saying the prior authorization is required. If they call our help desk, they can kind of walk through the process, or clinical department, steps that are involved, fail this medication, and then kind of the approval process.
So that brings up another question. So if I'm at the pharmacy and there's another drug that is preferred, does that happen at the pharmacy, or do I have to do something?
I would like to assume that the pharmacist would be pursuing this. So when the claim processes at the pharmacy, it hits the adjudication platform, so it'll reject saying step therapy. Call PROACT, the help desk number, or the clinical department number, and from that point, we kind of get the process going.
Okay.
But if members are frustrated or have questions,
Yes,
I urge them to call our help desk, because if our help desk can't answer the question, our clinical department surely can. So again, we pride ourselves on customer service, and please use the tools available if customers or if members are upset, and we will do everything in our power to kind of get through that process.
And that's been my experience with PROACT, but
I'm very happy to hear that. That's my day-to-day activities, so, yeah.
A question?
Another question over here.
I'll go first then. You mentioned for diabetics, there's 8 different drugs or treatments. How does the doctor know which one that you're selecting, or do you select all 8? Because I would assume some of the different treatments or drugs have different costs.
So step therapy, so let's say, and I was talking about a category. So diabetes is one of our categories that, excuse me, is the focus of our step therapy program. So you have DPP-4 inhibitors, which is a class of medications. There are 8 or 9 brand name drugs, all similar response, all similar ingredients. They do the same thing. What we do is prefer the lowest net cost drug. So if you go and get a prescription for Farxiga or Tradjenta, we will prefer Januvia or one of the lower cost brand name drugs. There are no generics, true generics for that class of medication.
Okay, so you prefer, but the doctor has written down one of the more expensive ones. What happens when they hit the pharmacist? Does the pharmacist know you have to use this other drug because that's what we have? Or do they just automatically, the pharmacist, say, okay, it's not a tier 2, it's a tier 3, and just charge the higher expensive drug?
So in my experience, I came from the retail setting before I became a clinical pharmacist for ProAct. I would hope that most of the pharmacists would realize that when it rejects for step therapy, that they realize, this class of drugs has 9 brand name drugs and they probably prefer a specific drug. The fact of knowing what tier the drug is in, that would be a call to ProAct, which will be resolved. If the pharmacist would call ProAct or the pharmacy technician, we could walk them through the steps of what's required to.
So you're basically saying if I come in and my prescription is for not the preferred drug, they will decline filling that drug, and then the pharmacist calls and finds out what the preferred drug is.
Exactly.
And then that's the one that's given to them.
Well, it's a little bit more complicated than that because we can't direct prescribing, so a pharmacist can't just change that medication. But being involved with the provider, if the provider is made aware of this, I think in most cases, unless there is a contraindication or intolerance or history of failure to that specific medication, they're usually willing to change to the preferred medication.
So I'm standing in front of the pharmacist and it's declined because it's the more expensive. And then the pharmacist calls in and finds out this other drug is the preferable one because it's less expensive. Does the pharmacist then call the doctor and see if he'll change his prescription, or does the person walk away with nothing and have to wait until the doctor gets back to it?
It's kind of, I would say, maybe a mix. So if the pharmacist reaches out to the prescriber, explains this, and they're willing to switch it, that can happen right at the pharmacy level. If not, it goes to our PA process. And I stress the point that we're pushing lowest net cost drug. So if this is a new medication, you will hit our process, our prior authorization process. If you've been on that medication, we have policies in place so that you don't walk away from the pharmacy without your medication. Okay. And to build off that, once we initiate our review and we receive all the information back from the prescriber, we try to turn that around in 48 to 72 hours after we receive that information. So it's a quick, I say a quick turnaround time. We try to get that taken care of as fast as we can.
Okay, so if the person tries your new drug and the former drug he liked better because it seemed to give him better results, then he can switch back to the other one?
100%, yep.
Okay, thank you.
We just build that in as a layer, a buffer between, let's say Januvia is, $300 a month and Tradjenta is $1,000. Why do you need that $1,000 drug without trying Januvia first? And that's all we're trying to do. But logic and clinical decision-making plays into that. So if you have tried Januvia or you have a contraindication to a certain drug and you need the more costly drug, we take that into consideration.
Thank you.
Mark?
I think my question is related to that, but you mentioned that you're evaluating the different drugs, and I was just wondering about side effects, if that's in the equation.
100%. So our P&T committee, our Pharmaceutics and Therapeutics Committee, takes all of that into account. So we go through the clinical guidelines, so the decision tools that your prescriber uses to treat your indications, disease states. We factor that into the drugs available to treat that. If there's brand, if there's generics available, side effects associated, side effect profiles, and all of that is kind of incorporated into our PA process. So again, common sense is incorporated into this as well. If you have a allergy, a drug allergy, that is all taken into account for sure.
Okay, thank you.
Okay, we're going to move on to Ken, talking about telemedicine and another trend coming forward.
Very good. Thank you all for giving me the opportunity to talk about the Excellus telemedicine program. This is a new avenue of care that we're offering to employer groups. The consortium does not have this option yet, but Don has assured me. I want to give you guys a first blush look at this, and you will see it repeatedly in further meetings coming up. So we're going to try and hit the highlights today of the telemedicine program. And once again, it's a new option that we are offering. Currently, you have the option to see a family care physician or a primary care physician, or go to an urgent care setting, or go to an emergency room. Now, with the Excelis telemedicine program, you have the ability to work with a board-certified doctor virtually via your computer, a tablet, a smartphone, or your phone, just talking with the physician. So we spent the last 2 years investigating how we were going to offer this opportunity to our members, and we chose to partner with a company called MD Live as our vendor of choice for the telemedicine program. MD Live has been around since 2009. They're based in Sunshine, Florida, which is nice to see. We finally have some sun after a week. But once again, we spent a lot of time vetting who would be the best option when it comes to security standpoint and level of service and ease of use. So we selected MD Live, and we rolled it out to our own employees, Excelis employees, in 2016, and now we're offering it to our members in 2017. Okay. Quick highlights again. Board-certified doctors. They have an average of 15 years of experience, and they are able to practice wherever you are in the United States. So we've seen a number of success stories with people who are using this program. If they have a child who goes to college in a different state, or if people are on vacation or traveling on the road, or just a couple months ago we had a blizzard on a Tuesday and Wednesday. And we've got a number of success stories where, a parent was home with their child and they used the telemedicine option, and then their spouse was able to bring home the prescription for their family members. So very easy to use, a great service. We can go to the next slide, please. And you can just see, hopefully helping people save some time and also save some money so that, if there's a little wait time to get in to see their regular family care physician, this is an option. Or hopefully avoid an expensive ER visit where, once again, people would have to wait a little bit longer for care. And then, once again, common low acuity issues or conditions can be taken care of with a telemedicine visit. So we want to help people get the care they need in an appropriate setting at the right time. You can see some of the conditions that are, once again, these are not life-threatening conditions. You can see some of the common conditions for adults and for children as well that can be used for the telemedicine. So lots of different options. Once again, a lot of times there may be people who have sinus infections on a regular basis or things like that. This is something that they can just check in and get it taken care of right away. I also want to be sensitive, since we do have some members from the medical community here. We at Excelis are working hard to partner with the different local providers and actually are opening this option up to the local providers to say, we will train you, MD Live will provide the training if you want to become part of this option. So, it's a very sensitive issue. It is something that is happening around the country. So, we are, of course, wanting to be a part of it as well, and also working closely with our local providers to let them know what we're doing, how we're doing it, and also offering them the opportunity to become a part of the program as well. Next slide, please. Once again, easy ways to get involved. So you can talk virtually over the phone and just have a phone conversation with the board-certified doctor. A care coordinator will connect you with the doctor. Or if you use your computer with a teleconference option or a video option or a smartphone or a tablet, you will actually be able to go online, select the doctor that is available. You can set it up for a visit at the time you need it, or you can schedule it at your convenience. Say, well, I have a lunchtime opening, I want to take care of it, or before work or after work or whenever. You can schedule it, select the doctor, select the time. You'll even be able to see a bio of the doctor and a brief description, and you can select male or female physician, whatever you're comfortable with. And then once again, the consultation will be happening virtually, and then afterwards, once again, if a prescription is needed, the doctor will be able to geolocate a pharmacy that's near you or send it to your pharmacy that you use on a regular basis to get that taken care of. In addition, if something happens afterwards, you can email the doctor that you've dealt with and they will communicate back to you just as part of the program. So you can, if you have questions about, this is still happening, or how long am I supposed to take this medication, they'll be able to interact with you after the call as well. You can just see some common estimates of acute cost of care, so normal costs for a primary care physician, an urgent care in our network, and an ER. So you can see an Excelis telemedicine visit is only $40. So once again, dealing with a board-certified doctor. The next slide, we can just show we did some estimates of what is happening. So you can actually see in 2015, the actual cost for the consortium, the average physician cost was $116, urgent care $256, and ER $1566. And then you can see the number of visits in each one of those categories. If we had a shift trying to be conservative in each of those categories to a telemedicine visit, you can see an example of some cost savings. And then you would have to counter that with the actual cost. We have a per contract per member cost that is built in if you decided to add it to your services. And that additional cost is 65 cents per contract per month. Just want to make sure we get that out there. But this is a great program, and you can see some potential cost savings along the way. Very good.
Thanks, Ken.
I will take any questions. Yes. Start right close to me.
Well, I'm just wondering from the physician, these physicians, they'll be fielding this within their normal workday? How does that work?
So yes, so the doctors that are on the telemedicine platform have it scheduled. You'll be able to see when they are available and when they're open. So yes, some doctors have it built into their work schedule. Some do it on hours that they're not working at their normal practice. Yep, but you'll be able to see when they're available. Yes, Beth.
How does this integrate with the electronic medical record of the patient?
Yes, so once again, it is a claim. Beth, you want to? Oh, I'm sorry, thank you. Yeah, it is a claim, so it will hit the Excelis network, and then it will go through just our normal electronic medical records as well. So it is.
So does the primary care physician get the information after the fact?
Very important question. When people are registering for the Excelis telemedicine program, they have the option to include their physician information. If the person does make that available, then it will be provided, the information will be sent to their physician or physician team, whoever is on there. But the person would have to authorize that, the member. Great. Any other questions? Yes.
I may have missed this, but when you're calling, are you contacting the same physician, or is it who's answering the phone?
You will be able to select the physician. You'll see bios of who is available at the time you want to have the visit. If you do like the physician, there is a way you can type in the physician's name if you want to use them over and over again.
Okay.
Great.
I guess the question is in regards to the medical records that the primary physician has. If you agree to have that updated to the service, then they can see what's been treated before in regards to whatever it is.
Very good question. So the person would register for the telemedicine program, the member. Mm-hmm. There is a medical history form or online that the person would fill out themselves, but there is no sharing of the Excelis claims data with the MD Live doctor. So it would be whatever the member puts in there themselves for their medical history for them and their family. And then once again, if there is a telemedicine visit, if the member says, I want to share this with my physician, it would go to them. But the telemedicine doctor would not have access to the claims history of the member.
So the telemetry doctor wouldn't see that I've been treated in the last 2 years for the same problem. If I told him that, he would be taking it on my word, not any facts.
That is correct. Yes, and there's a detailed medical history that we ask people to fill out during the registration. But yes, it would be based on the member's word.
Okay, thank you.
All right, moving on to the next section, we'll talk a little bit about financial impact, certain choices that the consortium makes, the employers make, and patients make. and then we'll turn it over for more discussion on preventive care and reducing care costs. So first and foremost, it's a little hard to read. It's small, and I apologize. But we did talk a little bit about actuarial values in terms of the different metal level plans, the platinum, the gold, the silver, and the bronze. We talked about the fact that we use a calculator each year to determine what that benefit level is going to be based on the parameters of the actuarial value. And this happens to be the actual calculator, if you will, or at least a snapshot of the face of the calculator. Behind this calculator is a whole bunch of data that Centers of Medicare and Medicaid Services puts together. We line up the benefits by plugging in the various deductibles, out-of-pocket maximum, co-insurances, co-pays, and it returns to us the value of the plan. In this particular case, this is the gold plan from this year. Keep it 79.7% within the range of 80% plus or minus 2%. So as a result, we didn't really have to make any benefit change to the program, but this was the actual calculation that we went through with the Joint Committee on Plan Structure and Design. And it's a choice that the consortium needs to make in terms of varying benefit levels to stay within those actuarial values. Obviously, if we're not in one of these actuarial value plans, the benefit design does impact overall premium, and whatever decisions are made at the collective bargaining table, et cetera, in terms of benefit level, obviously that impacts costs directly. In terms of decisions that you folks made, well, especially a lot of the towns and villages recently, choosing between the consortium and other avenues to provide your medical benefits to your employees and retirees, just a quick comparison of premiums. We showed this last year, updated it for this year. 2017, the metal level plans in the consortium versus the community rated medical level or metal level plans in Tompkins County, and I use Tompkins County as the basis for this comparison. One of the things that you'll note is we were still substantially below where Excellus's community rate is. As you go down the spectrum, though, in terms of level of coverage from platinum down to bronze, we get a little bit closer to the community rate when you get down to the bronze level. Those plans don't seem to change in premium as much because the benefit level is only 60% of the total cost of care. Their cost of care is growing a little bit slower than the others. Platinum, a much more robust health insurance program, that trend is a little bit higher. But even with that, we have a significant difference, obviously, between where the consortium's premiums are, and it continues to grow. You know, as Don mentioned in one of his slides, our rate of increase has been below that of the local community rates, and as a result of that, that gap between our price and their price will continue to grow over time. In terms of decisions we make as consumers, we talked a lot about this from a prescription drug perspective. Just to put a little bit of detail to it, the average price from last year for the consortium for a Tier 1 drug was $24.61. So if you can get to that level, obviously it's huge for the consortium. It's usually a cost savings to the member, certainly a much lower cost alternative for us. When you get to brand name drugs, and this would include all brand name drugs, including specialty, in this number, we get up to $432.86. Now that number gets skewed a bit by those specialty drugs, which are coming in just under $4,000 now, a script. Last year, that number was down around just over 3,200, I believe. The year before that, it was in the mid-2000s. The year before that, it was like 2,100. It is growing unbelievably fast. So certainly, decisions we make, not only as patients, but decisions our providers make in terms of what medications they dispense, can have a huge impact on our overall costs. And then also in terms of care centers, obviously we talked a lot about urgent care, office visits, emergency room, et cetera. Again, just to put some dollars to the decisions that we're making. An average office visit's under $120. Urgent care is just under $300. And then emergency room, anywhere from $1,300 to $1,400 in terms of overall cost to the plan. And obviously, depending on where we go, it impacts our premium. Excuse me. The last item is where we get services in network versus out of network. And we talked a bit about that in terms of our cost savings. And with that, I'll turn it over back to Don for preventive health care.
Sure. So we're running a little bit over, but Ken and I will finish this last bit up on preventive health care in 10 minutes. So our focus up to now has been to work within the system when you have illness or injury, and now there's another set of knowledge and information which talks about making preventive health care a priority that will save you money. So next slide is that from your Owning Your Own Health Committee, this statement was created about wellness. A community that values and practices preventive health care to promote health and prevent disease. It's moving along, thank you. When you are healthy, you can concentrate on things that you want to think about. Typically, you're happier and can do things that will make it easier for you with your recreational activities. A healthy lifestyle can prevent you from getting chronic diseases, or if you have one that's started, move you to a moderate risk category and buying you many more years of healthiness. Medical research has shown that knowing your numbers, blood pressure, cholesterol, glucose, etc., and then making changes to get them back into the normal range will then keep you there and with a longer life with minimal interactions with the healthcare system. Excellus has a robust wellness information system that Ken wants to connect you with. Ken.
Thank you, Don.
I have one. I guess I have one more, sorry. So let's put some numbers here on the wellness. If you remember from earlier today that 21% of our population incurs 80% of the claims cost, but also Excellus regional data and national studies show that 35% of the total patients have chronic conditions that account for 64% of the total claims spend. So managing chronic conditions is really critical to the Health Consortium as well as to you personally. So this spend not only affects the consortium, but also impacts your out-of-pocket spend. But the good news is most chronic diseases are very easy to treat if they're found early. Patients can be moved from the high risk and to a cost that is at a medium and low risk category under medically supervised programs. So this, I see, I jumped way ahead. I'm going to go back to Ken.
Thank you, Don. Yes, we will. In the last 6 years that I've been with Excellus, our wellness and member care management programs have really light years improved virtually on our website and in person. You can see some of the information that we have above. We actually have the ability for our members to talk with one of our registered nurses in our member care management team and get information and the help that they need and get guided kind of in the appropriate navigate through the healthcare system or any questions that they may have. So working with one of our registered nurses, they can enroll in one of our member care management programs like there are diabetes program or COPD program or depression program. So they can get the help they need and also that the resources they need by contacting, you can see the 877 number or the 800 number to talk with one of our registered nurses and really get on the path to working with someone on a regular basis as kind of a coach and a resource provider. Next slide, please. Great. You can see once again some of the innovations with our website. Some of our preventative health information. If you click on those little plus signs, it will explode into more information that people can download or contact numbers that people can reach when it comes to each one of those categories. And once again, all free resources. You can see the main web link below, excellusbcbs.com/healthy living. If you get a chance, we encourage people to check it out. And once again, it's all optimized. So whether you're looking at it at a computer or a tablet or a phone, it's right at your fingertips and easy to see. Thank you. Next slide. Managing conditions, once again, when it comes to working with one of our registered nurses, it's at your fingertips. The 800 number is there. Some people get outreach from us depending on the severity of their condition, or once again, people can kind of self-report and enroll themselves in the program. And you can see if you click on each one of those, it will break out the different conditions that are available and the additional resources that are available as well. Thank you. Behavioral health, once again, becoming an important topic, more so than ever. People are so busy nowadays, life is so complicated. So when it comes to the mental health and substance abuse, it's really starting to take high priority in our organization. You can see the contact number available to deal with one of our behavioral health specialists, and then once again, information at people's fingertips that is available on our website and our platforms. We want to make sure, like Beth was saying earlier, we want people to make sure they get their preventative health, their annual screenings and all the other information that is a part of them and is free with their membership to Excellus. So you can see we have it broken down, what people should be getting depending on their age, depending on their gender, and then more information covering all the key areas of someone's life and someone's health. Taking medications, once again, we work closely with PROACT, and we also have our own team of people as well to help educate people about making sure that they are taking their medications appropriately and as directed. We want to make sure that people are not wasting their medications or not using them and are using them appropriately, so we have information on our site as well. And then another way, once again, people are using Facebook and social media and lots of other platforms. So Excellus has teamed up with a number of organizations in upstate New York to create a website and a blog called healthierupstate.org. And it's a nice way, very user-friendly. There's lots of videos. Once again, it has more of a social media theme to it. And you can see there's different things. It's, once again, a little trendier, a little more fun to look at than our website. So, just a neat way to get information and health about it and making it in a community-type approach.
All right, so you caught me at being an Energizer buddy, and I went right through the slide already. But just to highlight that the chronic conditions are really a big expense to you personally as well as to the consortium. But there are ways to get around this, and moving on to the next slide. This slide shows that healthcare actually doubles in 8 years. And our own modeling, we're using 8% increase when we're doing our budgeting, which says that every 8 years, 8 to 10 years, the cost of healthcare will double. So making wellness a priority at the employer and individual level can reduce the rate of growth, as shown in the next slide. Consortium has partnered with Interactive Health through the Blue for You program to measure your numbers and coach you to maintain or reduce them to a normal range. When this program is embraced by the majority of the subscribers in the group, this chart shows that we can collectively bend this curve. Combining this comprehensive and diligent wellness program with the other hints you've received today can save you real money over your lifetime. Data shows that starting early with a healthy lifestyle choices can also reduce your healthcare cost spend over your life and allow you more time with your friends and family than you spend with your doctor. So moving on to the next slide, the Blue for You program that I just highlighted is attached as a free benefit to our meta-level plans, and folks can sign up for that are on meta-level plans in February and March of each year. If you're on one of these plans, keep an eye out for next winter's announcements about the upcoming registration. So there are definite benefits to having a wellness program. For the patient, the ability to work and play harder, the ability to heal quicker, and lower subscriber costs due to lower health care costs. And for the consortium, there are lower claims expense, which then leads to lower premium growth. So that's our pitch on preventive health care, another choice that you have in managing your costs. You've been asking great questions along the way, but if there are any further ones you need to ask, this is a great time. You have your presenters here all in one place. Mark.
I'm just wondering what the percentage or proportion buy-in on these wellness programs is with the patients, with the...
Right now, we've only been able to roll this out to like 100 or so, Beth? And we're probably getting, it's less than 10% that are joining on. And so we have not made this a cultural thing within the consortium or within our community. That is something our Owning Your Own Health Committee is working on to try to make this a bigger priority. But the reason for bringing it forward today is that we can recognize this as we talk to our associates, that preventive health care can save you real money over time, and it can you can actually bend the curve of claim growth.
Follow up, that was a great figure you showed about that outcome.
Yes.
Starting in 2010. So that was basically when the Health Consortium originated. Is that?
No, that was actually for another company,
Oh.
and they actually have got over 80% of their employees participating in the Blue for You style program. And so if we were to get, so those savings are achievable if we have create a culture of wellness. They will not only be tinkering around the edges until we make that the case, but tinkering around the edges can affect you personally. Then since you're all responsible for your own checkbook and balancing your budget, then why not start on wellness whenever you can?
It's really a nice way to help people become better stewards of their own health, and the coaching is fantastic to be able to, sometimes people work with a coach for other things, whether it's golf or their fitness. Why not have a coach you can talk to about your own lifestyle and what you want to accomplish?
So I'll just say one more thing. So that company probably had some sort of way to incentivize participation.
The company does not, but the consortium or the employer would need to develop those incentives. And so that's part of what we're discussing at the Owning Your Own Health Committee, then moving it on to other committees as we work out a strategy that we think is workable.
I think the question had to do with the employer offering an incentive. Yes. I mean, to get a high percentage of people like that, there's going to be some kind of impact to the member. Generally speaking, if you don't participate in wellness in the private sector, you're paying more in premium. Okay. Those that participate in wellness pay a lower rate. Typically in the municipal environment, we're not there. It's a voluntary program. We're never going to probably achieve 80% participation or anywhere in that ballpark, but we need to do better than 10. And we can certainly achieve that with better communication and education.
Is that because there's a prohibition in the municipal realm?
It's just, it'll be difficult to negotiate.
Okay.
Yeah, with collective bargaining agreements and unions, it's just the reality of it.
I totally understand.
Yeah.
So.
Any other questions? Please, Debbie.
Ken, on the telemedicine, you said it would be like $40 a visit. Right. How do they pay for that? Do they get billed for that, or do they have to pay for that when they're online with them?
Yes, the person pays at the time of visit. So what's nice is once they pre-register, when they register, they have to put in their Excelis member ID number, and then it's real-time accessible. So MD Live will know what plan they are on, whether they have to pay the $40 or if you guys designate a certain copay for it. So yes, MD Live will know exactly what payment has to take place based on the person's plan, but they do pay at the time of service.
You don't keep their credit card information. They got to enter it each time?
Nope. People can keep it on file if they want, or they can do it every time. There is the option.
Any other questions? So I'll just leave you with a thank you for coming and being part of this. Hopefully it was worth your time. And if you have suggestions for future events or comments about today's presentation that can help us be better in the future, we'd love that. So thank you and have a great day.
Thank you.